All right. Good morning. I'd like to call this public hearing of the Committee on Health to order. Today is Thursday, October 30th, 2025. The time is 9:31 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We're in room 123 of the John A. Wilson Building, and this is a hybrid meeting where we have some public witnesses who are testifying both in person and virtually. The government witnesses will be here testifying in person. Today, we will consider two bills before the committee. We'll start with the public and government testimony for Bill 26-0414, the Community Health Amendment Act of 2025. We will then turn to the public and government testimony for Bill 26-159, the PrEP DC Act of 2025. I introduced Bill 26-414 on October 6, 2025, along with Chairman Middleton and council members Allen, Pinto, Fruman, Parker, Louis George, Bonds, and Robert White. This bill would ensure the continued access to critical immunizations to protect the public health of District of Columbia residents, visitors, and workers. It would permanently codify the changes approved by the council on an emergency and temporary basis through the Community Health Emergency Amendment Act of 2025 and the temporary, which were both approved unanimously on September 17th. Vaccines are evidence based and extremely effective tools to protect the public from severe illness and death from infectious diseases. Even though certain populations like seniors, children, and those who are immunocompromised are more likely to become severely ill, a basic tenet of the public health science is that vaccines work best when everyone, including healthy individuals, are vaccinated. Unfortunately, in recent months, federal actions have created uncertainty and confusion about the future of evidence based federal immunization recommendations. This led to several large pharmacy chains announcing in early September that they would not offer certain vaccines in some states, including the district, where local laws tied pharmacists' ability to independently administer a vaccine to federal immunization recommendations. Although the emergency and temporary legislation passed the council, that only provides access for a short period of time, permanent legislation is needed for a long term solution. This bill would permanently allow pharmacists and pharmacy technicians in the district to administer vaccines recommended by a competent medical or public health organization as designated by DC Health. This year, DC Health considered the recommendations of the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists. This bill also aligns with language in our consent for vaccines for minors law with this new standard. Although this bill does not address insurance coverage for vaccines, I want to note that the National Trade Group for Health Insurance Companies, AHIP, announced in September that they will continue to cover all currently recommended vaccines, including this year's COVID and influenza vaccines, through the end of 2026. The district's Department of Insurance, Securities, and Banking also issued a bulletin last month requiring the district health plans to cover all vaccinations included in the federal immunization guidelines as of December 21st, 2024, with no cost sharing. We applaud these decisions, which will ensure that vaccines remain affordable for residents with private and public insurance. I don't have any of my colleagues here, but they'll be joining shortly. We're going to go to the first panel of witnesses. Just a reminder for folks, witnesses will have 3 minutes to testify. You're welcome to submit longer written testimony for the record. I hope you will be conscientious of your time so that everyone has an opportunity to speak today, and there's timers all around. Okay. So in person, we have Dr. Sarah Candler from the DC chapter of American College of Physicians, Constance Bohan, Ruth Hollow or Hollow, okay, and Artemis Eden. Artemis Eden here. All right. Okay, we'll go with this panel and then we'll switch we'll just call the virtual folks up now and we'll just do it all at once. Dr. Dot Winston, who's the current president of the Medical Society of DC, Dr. Clint Peebles, and Sanaya Daya. All right, Dr. Candler, when you're ready, you just hit the button right in front of you. There you go.
Thank you, Council Member. Thank you for having me. My name is Dr. Sarah Candler. I'm a board-certified internal medicine physician specializing in primary care in Northeast DC, speaking on behalf of myself and my professional organization, the DC chapter of the American College of Physicians, ACP, in support of DC Council Bill 26-0414, the Community Health Amendment Act of 2025. I work in a small private practice and take care of patients over 18 who have Medicaid, Medicare, private insurance, or are self-paying when they're uninsured. In any given day, I see up to 22 patients for chronic conditions like diabetes, heart failure, depression. I diagnose cancer, I treat sprained ankles, and most importantly, I try to keep people from getting sick in the first place through routine checkups, screenings, and vaccinations. I won't belabor the science. By passing the emergency and temporary amendments preceding the bill last month, you have proven that you get it. Vaccines are safe, effective, and should be accessible to all people in the district without the burden of an additional physician visit when physician-led recommendations deem it reasonable to do so. Thank you for following the science. While many of us can administer immunizations in our practices, not all can. The burden on physicians prior to the passage of your emergency and temporary amendments was not just the time it took to write prescriptions, but the time required to explain what had changed, why they might need a prescription in the first place when last spring they did not, reassuring hesitant patients that the science has not changed and that vaccines are still safe, effective, and recommended. This is not a new invitation for medical care to occur asynchronously from a physician visit. This bill will codify previously acceptable and safe practices, which we know decrease barriers to vaccines, increasing the number of people protected and protecting others in the district. For any who are unclear which competent medical or public health organization the DC Health Director might turn to for its future vaccine determinations, I'm here to reassure you that the physician community has your back. We believe healthcare is a team sport, and physicians remain the leader of that team. Nationally, the American College of Physicians and others have joined the Vaccine Integrity Project, an initiative led by the Center for Disease Research and Policy, CIDRAP, at the University of Minnesota. It brings together vaccine experts and professional societies to provide recommendations on vaccines for the U.S. population. Our local chapter will be notified as these resources become available and will commit to ensuring they're shared with the appropriate members of DC Health. Locally, the Medical Society of DC has created a federal policy task force, of which I am co-chair, in order to monitor federal policies that could adversely affect the health of our district. It is out of this task force that the initial request for your emergency amendments on vaccination policies arose. We will remain vigilant of similar threats to the health and safety of the district and will continue to bring evidence-based recommendations to the council as needed. We have your back, and thank you for having ours. Thank you again for the consideration of this bill and for your commitment to evidence-based immunization practices in the district.
Thank you, Dr. Candler. All right, Dr. Bohan, you're next, but they need you to lean into the mic. Just hug it just a little or pull it closer to you. Yeah, and then hit your button so they could hear you.
Good morning.
There we go.
My name is Dr. Constance Bohan. I'm an OBGYN physician who's been in private practice here in the District of Columbia since 1982. I'm an assistant clinical professor of obstetrics and gynecology at the George Washington School of Medicine and an obstetrical house officer at Sibley Hospital. I serve as a member of the DC Maternal Mortality Review Committee, the MMRC. Today, I'm here on behalf of the District of Columbia section of the American College of Obstetricians and Gynecologists, otherwise referred to as ACOG, which is pleased to support this bill. I would like to thank Chairman Phil Menderson, Council members Henderson, Allen, Pinto, Fruman, Parker, George, Bonds, and White Jr. for your sponsorship of B26-0414, the Community Health Amendment Act of 2025. As doctors, we know that vaccines are essential and can save lives. It is estimated that in the last 50 years, nearly 150 million deaths worldwide have been prevented by vaccines. Advancements in new vaccines continue to demonstrate data that show the power of immunization. For example, between 2008 and 2022, as a result of the uptake of the human papillomavirus, the CDC reported a drop of 79% in precancer incidence in women aged 20 to 24. The cancer-preventing HPV vaccine is also saving lives. A recent study showed a precipitous 62% decrease in cervical cancer deaths among women under the age of 25. And of course, we know that the COVID vaccine has not only protected pregnant patients from experiencing the severe outcomes associated with COVID infection during pregnancy, it has also protected their infants. Research has shown that the vast majority of infants hospitalized due to COVID infection were born to unvaccinated mothers. Because it is safe and effective, ACOG recommends COVID vaccination for every pregnant person. Historically, pharmacists' authority to provide vaccines is dependent on recommendations from the CDC. Unfortunately, recent attempts to politicize healthcare and restrict the CDC have put the access to vaccines at risk. Although Councilmember Henderson's emergency legislation to protect pharmacy access to vaccines, including the critical COVID-19, influenza, and RSV vaccines have been in effect since September, DC needs a stronger, permanent solution to ensure that people are able to receive the vaccines they need to protect their health and their safety at the pharmacy of their choice. ACOG strongly supports the permanent protection of the ability of pharmacists and pharmacy technicians to administer life-saving vaccines without a prescription to DC residents, visitors, and workers who choose to protect themselves through immunization. ACOG also supports the bill's provision that the vaccines covered by this bill are those that are recommended by a competent medical or public health organization as designated by DC Health, including ACOG. We urge the DC Council to pass B26-0414 in order to permanently ensure that pharmacists and pharmacy technicians can administer life-saving vaccines without a prescription in accordance with recommendations from competent authorities such as ACOG. Thank you.
Thank you. Dr. Hollow.
Good morning, Chairperson Henderson. My name is Ruth Hollow. I'm a pediatrician and the Associate Chief of General Pediatrics at Children's National Hospital. Children's National has been serving the nation's capital since 1870, and we're proud to be among the top 10 children's hospital by the U.S. News and World Report. Thank you for the opportunity to provide testimony in support of Bill 26-0414. Children's National is deeply committed to advancing the health of every child in the District of Columbia. We provide care to over 76,000 district children and families each year and partner with community stakeholders to ensure access to essential health services such as immunizations is convenient and consistent year-round. Children's National strongly supports this legislation because it allows trained and certified pharmacy technicians to administer vaccines under pharmacist supervision, reducing barriers for eligible children and families to receive timely vaccinations, including COVID-19 vaccine. At Children's National, we offer immunizations across all 5 of our primary care locations in the District of Columbia, aligning with the American Academy of Pediatrics recommendations for vaccinations. In fiscal year 2025, we provided more than 63,000 immunizations, reflecting our deep commitment to ensuring children are protected against preventable diseases. While we're proud of our impact, we also recognize that families need multiple convenient options to protect their children. Expanding the number of qualified health professionals to include pharmacy technicians and pharmacists helps make that possible and increases the number of access points for families. A core priority for Children's National Division of General Peds is ensuring that children are up to date on their required immunizations for school readiness. To achieve this, we engage in continuous outreach to families throughout the year through clinics, mobile health units, and community events. We also offer extended clinic hours to improve access to care and to help close immunization gaps. This bill will give families more opportunities in more locations at more convenient times to get vaccinated. Children's National supports this legislation because it strengthens our collective ability to offer families timely access to immunizations. We urge the committee to advance the permanent legislation and look forward to continuing to partner with the district to ensure children thrive and grow up stronger. Thank you.
Thank you. Dr. Winston? Dr. Winston, if you're speaking, you're on mute. Okay. We'll come back to you. Dr. Peebles?
Thank you, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. I'm Dr. Clint Peebles, a board-certified dermatologist practicing here in the district and a member of the Medical Society of the District of Columbia, where I currently serve on the board of directors and in the incoming president-elect. I'm here in strong support personally of the Community Health Amendment Act, which ensures that healthcare providers in DC can order and administer all immunizations recommended by trusted medical and public health authorities. Vaccines are among the most powerful evidence-based tools we have to prevent disease and to protect our community. During COVID-19 and mpox, just to name a few, we saw how fragmented authority and unclear rules about who could vaccinate created unnecessary barriers and slowed our response. This bill brings the clarity we need to make vaccine access consistent, rapid, and equitable. As a dermatologist specializing in complex medical dermatology, I care for patients every day with serious immune-mediated conditions, cutaneous lupus, autoimmune blistering diseases, extensive psoriasis, and hidradenitis suppurativa, among many others. These conditions often require advanced therapies that suppress the immune system, and a cornerstone of their safe and effective management is ensuring protection against preventable infections. And that makes timely vaccination not optional, but essential, and sometimes even life-saving. And these are conversations I have literally every day. This legislation ensures that healthcare providers, including pharmacists, can continue providing immunizations under evidence-based guidelines and within the rulemaking authority of this council and the Department of Health, adhering to established immunization schedules that are driven by clear evidence-based factors, not by individualized medical evaluation. And for that reason, the Community Health Amendment Act should be seen as reinforcing team-based care, improving efficiency, and expanding access within existing parameters, not as a precedent for broader diagnostic or prescriptive authority. And by maintaining this clear boundary, we uphold patient safety, professional integrity, and the cooperative spirit that underpins effective public health. This bill achieves an important and practical goal, ensuring permanent vaccine access while preserving professional collaboration and accountability. And I urge the council to pass it. Thank you for your time and your continued commitment to the health of district residents. Thank you.
Thank you. Dr. Winston, are you with us?
Yes, I am with you. I do apologize. I was with a patient.
Oh,
I'm
no
back
problem. Go
now.
ahead.
Hold on. Let me turn my video on. Okay, here. I'll just go ahead and start. Oh, my video's there. Perfect. Okay. Thanks everyone. I am Dr. Winston. I'm the current president of the Medical Society of DC. Thank you for the opportunity to testify about this important work. We first want to thank you for the opportunity for us to talk about B26-0414, the Community Health Amendment Act. We strongly support science-based vaccines and a rigorously tested vaccination schedule. Last month, the MSDC Board of Directors affirmed our own position by passing an updated policy on immunizations. That policy reads that we affirm that immunizations are among the safest and most cost-effective public health interventions preventing disease, disability, and death. MSDC supports universal access to CDC and ACIP recommended vaccines without cost sharing and through equitable, culturally responsive distribution across all populations. Also, MSDC is committed to investing evidence-based vaccine policy that protects all district residents and reduces health disparities, advocating for district regulations and public health funding that strengthens vaccine supply chains and enable transparent reporting of immunization coverage rates across the district. In terms of pediatric vaccines, we support the American Academy of Pediatrics recommended immunization schedule as a requirement for all district children attending childcare or school, with exemptions only for specific medical contraindications. The society supported the emergency version of this legislation and supports this version. It is essential that DC residents have access to safe and effective vaccines, and that there is a body of knowledge to support when vaccines should be administered. As we enter cold, flu, and COVID season, access to seasonal vaccines is incredibly important to keep our emergency rooms clear and our populations healthy. The society also commends the committee for highlighting the work of various professional organizations that help to publish rigorous vaccines and schedules. With the chaos at the HSS, highlighting these medical societies and their work is essential to show that there are still places for proven scientific advice. We only asked DC Health through our testimony to also consider the American College of Physicians vaccine schedule in the future as a vaccine schedule source. I also want to take this opportunity to highlight the Department of Insurance, Securities and Banking, and the Department of Healthcare Finance and the insurance industry in general. Their commitment to ensure scientifically proven vaccines may be obtained cost-free to patients is very important to widespread vaccinations. Joining me today are a number of physicians who can provide their specialties perspective, importance of vaccines, and the entire DC medical community is available to work with the council and administration on an effective vaccine policy, just as we have for decades. Thank you.
Thank you. Sanaya Daya?
Hi, all. Thank you for having me here. My name is Sneha Daya. I'm an associate professor of internal medicine and pediatrics at Georgetown University School of Medicine, and I'm a practicing pediatrician and internist for over 15 years, currently caring for families in both primary care and hospital settings in DC. As a primary care doctor, I've witnessed firsthand the critical role that timely vaccination plays in protecting children and our broader community from preventable diseases. The AAP, or the American Academy of Pediatrics, has long maintained that childhood immunizations are one of the most effective public health interventions available, and their guidelines emphasize the importance of ensuring that all children receive recommended vaccines on schedule. Additionally, I have personally observed as our population ages, we are seeing the resurgence of preventable diseases, and it's become imperative to protect our elderly and immunocompromised patients from these conditions that cause significant morbidity and mortality, as we witnessed during the COVID-19 pandemic. Unfortunately, as primary care doctors, we're seeing the consequences of declining vaccination rates across the U.S. During the 2024-2025 school year, 36 states and DC had increased school vaccine exemption rates compared to the year prior, and 17 states had exemptions greater than 5%. Outbreaks of measles, pertussis, and other vaccine-preventable diseases have reemerged in communities where immunization rates have dropped. To date, 1648 cases of measles have been reported, almost 2,000, including 3 deaths due to the disease. And these outbreaks not only endanger the health of unvaccinated children, but also put at risk infants, immunocompromised individuals, and others who cannot be vaccinated for medical reasons. Furthermore, vaccines such as the flu vaccine have improved efficacy, with prelim data from the Southern Hemisphere showing that vaccination reduced medically attended influenza-associated illness by about a half for this year's vaccine. The Community Health Amendment Act of 2025 is a vital step forward. It will ensure that district residents, visitors, and workers can receive essential immunizations in a timely and convenient manner, especially during these times of uncertainty or changes in federal recommendations. The AAP and other leading organizations have issued clear evidence-based vaccine recommendations, and this legislation wisely allows DC Health to designate such organizations as authorities for immunization schedule. This legislation will help safeguard the health of our children and communities by making vaccines more accessible, reducing preventable illness, and aligning our laws with the best available medical guidance. Thank you for your attention and your commitment to public health.
Thank you. And thank you to all of the public witnesses. I don't think we've ever had an entire public witness schedule of nothing but physicians. So thank you. So exciting. I think that one of the things that you all sort of talked about, I wrote down some of these quotes. Healthcare is a team sport. We're talking about collective ability, cooperative spirit that underpins public health. And public health is a group project. And right now we would be like, I don't know, a C, maybe, if that. Unfortunately, the leadership is sort of adding, I think, some complexities to our ability to all sort of get on the same page about how we kind of move forward. In listening to the testimony, none of you raised any concerns or any edits that you would like to see, but I want to give an opportunity in case I missed something, if there are some edits or adjustments that you feel like is important for the legislation. Okay, all right. Well, that's helpful. Like I said, sort of in the opening statement, this doesn't tackle the insurance portion, which I'm sure is a conversation that we'll need to have at some point. Luckily, AHIP and DISB have sort of signaled that at least we have a year to kind of figure this out. And also in that time, see where ASIP, man, we use a lot of acronyms, but kind of see where ASIP is going to go. It is just a very weird time. It was actually, Dr. Bohan, I was reading yesterday, Texas is suing Tylenol based on nothing, no evidence whatsoever. I'm like, that is a frivolous lawsuit if I've ever seen one, but okay, sure. Let's have this conversation in court, I guess. I was in South Carolina a few weeks ago and the governor's talking about, needing more exemptions on vaccines. I'm like, sir, you have a measles outbreak in your state. But okay, sure, freedom to have measles and chickenpox. It's just kind of odd to me that they literally had to have students were required to quarantine because they had not been vaccinated. Like the school system is like, no, you can't actually come to school because we don't know if this is going to be safe for you. So we're just kind of in a weird time. But I want to extend a thank you to all of you who are on the front lines of public health and for being here and testifying today. If we don't have a copy of your testimony, can you make sure you upload it for the record? And then we'll go on to our government witness. Thank you. All right, so now I'll call our government witness, Dr. Ayanna Bennett, who is the director of DC Health. All right, Dr. Bennett, before you begin with your testimony, I do need to swear you in. You don't have to stand, but right hand in the screen. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right. Please begin.
Good morning,
Morning.
Chairperson Henderson, council members, ONA, the committee staff.
Now, Dr. Bennett, you're going to have to lean in.
Okay,
Thank you.
I recognize the mic issue. I just want to thank, before any of them run out of the room, all of the physicians who've come to testify. I think it's actually makes entire sense that you have an entire list of physicians coming to speak about this issue, partly because I actually think we are getting a B+, maybe an A- on vaccines, because realistically, while there is misalignment of federal public health on this issue, there continues to be and has been uninterrupted overwhelming consensus between the public health and medical community on the safety and efficacy of vaccines, which vaccines should be given, the fact that we should continue as we have been with vaccines for decades. So what we are all standing here for is to really, really stand firmly for the continuation of effective strategies that we have been making real for decades, and that there is an overwhelming consensus. We are maybe not as loud, maybe fewer of us are on CNN, but there is not controversy and disagreement in the medical community. The public health community that is on the ground, local public health, even state public health, is not in disagreement. And you can see that by the actions that we took and by the actions that all the other states took. So I'm going to go through some testimony, but I just want to say your presence here is the biggest testimony about where we stand right now on this issue. So I'm going to provide some testimony in support of the act, the Community Health Amendment Act of 2025. The legislation is meant to ensure that vaccine access is available to through district pharmacies, which is critical during the annual respiratory disease season and throughout the year as vaccines are given. So the United States experiences a surge in respiratory diseases such as influenza, COVID, and RSV during the colder months. This increases in the rates is totally expected and happens every year, but it causes a strain on the district's healthcare system when that happens. During the first quarter of 2025, there were 2,309 influenza-related ED visits. And in that season, there were 532 ED visits for RSV. So those ED visits and hospitalizations, they present a challenge to those patients, those adverse health outcomes, but also to their families, to their employers, to the community at large. But thankfully, we have vaccines as a response to that. They're the safest and most effective way to protect people against these respiratory diseases. These vaccines have undergone extensive clinical testing and have been approved by the Food and Drug Administration, who's responsible for determining safety. And that is really the conscripted entirety of their role, is something safe enough to sell to people in the United States. And then once that happens, we take them to the medical community, who then uses them to make reductions in disease transmission, severity of illness, and death, which we have seen. This is particularly important for people at an increased risk of serious complications from these diseases, and that includes infants and children, seniors, and those with underlying health issues. During the district's 2024-25 respiratory season, 63% of RSV-related ED visits were among infants and young children, as we expect, and nationally, over 81% of all COVID-related deaths occurred in people over the age of 65. So to limit negative incomes for these populations and transmission to these vulnerable populations, it's important for people to have access to these vaccines as conveniently as possible, which is often at a pharmacy. So according to the data from the 23-24 respiratory season, we know that the most common vaccination setting for adults is in a pharmacy, including 74% of district seniors who receive their vaccination in non-medical settings primarily, and that is overwhelmingly pharmacies. Therefore, to keep the district's most vulnerable safe, it's critical that we protect convenient and simple access to vaccines. The Community Health Amendment Act of 2025 permanently codifies existing changes that were made in September through emergency legislation. It provides the director of the Department of Public Health with the authority to designate competent medical and public health organizations for the purpose of utilizing their immunization guidelines. The vaccines in these guidelines could then be administered by pharmacists and pharmacy technicians and be accessed by certain eligible minors. Following the passage of that emergency legislation, I issued a public notice that designates the American College of Obstetricians and Gynecologists, ACOG, the American Academy of Pediatrics, AAP, and the American Academy of Family Physicians as such organizations. When I see the ACP final schedule, I'm more than happy to amend the designation to include it. These organizations were chosen given their guidance is informed by the nation's leading medical experts, and they're trusted for similar immunization standards by other jurisdictions across the country. I will add that these are the tools that physicians in practice use to discuss these vaccines with their patients and to determine which vaccine a patient will get. So by having these be the guidelines that pharmacists use, we're actually aligning practice across the healthcare provider community so that patients are getting consistent advice and consistent care across all settings. As the district's public health officer, I work to make sure effective public health interventions are available across all 8 wards. However, when there are unpredictable changes to national immunization standards or delays and updates, residents and even worse, providers in this case may be confused and be unable to provide vaccinations. In response, DC Health needs the authority to protect the district's public health through up-to-date and evidence-informed immunization standards. This legislation provides that authority by ensuring pharmacy professionals are empowered with the scope of practice to administer vaccines that are safe, effective, and sought after by members of the community. In closing, DC Health strongly supports this legislation as it will strengthen immunization coverage across the district, save lives, and reduce hospitalizations and illness. I would also like to acknowledge the district's healthcare finance and insurance agencies for ensuring coverage is maintained for these vaccines. Thank you for providing me the opportunity to testify, and I'm open for any questions you have.
Great. Thank you, Dr. Bennett. And I want to thank you and your team. I feel like this was one of those issues where sometimes people are like, you guys aren't working. And I'm like, we don't have to put out a press release about every conversation that we have, but we were very much in conversation about how do we respond to make sure that district residents don't have to travel to Maryland or Virginia in order to get access to a vaccine. Beyond that, we had been working towards expanding the ability of pharmacists and pharmacy techs to be able to provide and administer vaccines post the public health emergency. And so it would seem foolish for us to sort of hustle backwards because that had been so successful in expanding access. The ability, love physicians, love the PCP community, but if I could just pop into a CVS to get my shot as opposed to having to get an appointment and wait 4 weeks, I'm going to take the pharmacy each and every time. I just have a few questions for you, just so we need to make sure that we do have a strong record.
Yes.
So the emergency legislation, or excuse me, the emergency version of this legislation went into effect after the mayor signed it on September 22nd. I do want to give a shout out to our general counsel, our secretary's office, the mayor's office of policy legislative affairs, and the mayor's office, because we often don't get a 2-day turnaround on bills in this building, but folks were certainly working hand in hand together. Once DC Health was notified that it was in effect, how long did it take for you all to issue the public notice?
I'm sorry, I'm not sure what I'm being handed. We were already prepared to do that. So it was right away after that.
Okay. And
Go ahead.
how was the notice sent to pharmacies?
So we directly communicate with providers and pharmacists. So initially we sent a notice to providers to let them know that this problem existed so that they prepared for all the people who were going to be coming asking for prescriptions until we got this done. And then we sent a notice to providers and to pharmacists letting them know the change. We did that through the communication they have with the pharmacy board. And then we always do direct email communication with all of our members.
Okay. If the permanent version of this bill is approved, what will the standard process and timeline be for drafting or issuing notices? Will it be annually? I guess the question is, what type of cadence should folks expect of a change?
Okay, I understand. So the recommendations for vaccines are generally updated annually. Even when there isn't a major change, there's often at least a small directive change. So if there is not any change in the recommendations, then we won't change the notice, but we will keep abreast of all of the most current recommendations from all of the national medical societies and act accordingly.
Okay. The bill authorizes the director of the Department of Health to use base guidance on vaccine administration on either the Advisory Committee on Immunization Practices of the Centers for Disease Control and Prevention, or a competent medical or public health organization. You stated in your testimony that in this year's notice, you named ACOG, AAP, and AAFP as these organizations. Were the organizations' recommendations consistent with each other this year? Or did anyone have a conflicting guidance?
The recommendations are consistent, and they generally are. This is not a new activity for our medical community. The AAP has put out guidelines forever, and they were part of traditionally the ACIP process of developing the guidelines. So they're generally guidelines change when there is really strong evidence and overwhelming clinical consensus that we need to practice differently. So the controversies that we have sort of seen reported are not based on differences in scientific reads necessarily.
It's politics.
It's something else. And so there isn't a lot of daylight between groups because they're reading the same science and talking together. So these groups all have corresponded with each other. Part of what the Vaccine Integrity Project did at the beginning of the year was help bring everybody together and understand where insurance and other parts of the spectrum were. So I don't expect there to be a lot of difference in the guidelines. If there were, what we would do is refer to the groups whose area is that age group. So we might designate AAP for children under the age of 18 or ACOG for pregnant women, but we don't expect that will be necessary because they are looking at the same science and discussing with each other. If someone had an objection, it would be based on something they had seen, and that would be communicated with other groups, and those differences would be generally worked out.
Okay. Does DC Health have any access to real-time data about vaccination rates for, say, this fall?
We do.
Are we in a concerning place when it comes to flu and COVID booster?
We have best rates around COVID, but we do have general vaccine uptake rates. For the most part, we have better rates around VFC because that we directly administer. What we have seen from reporting from our pharmacies is that there were a couple of weeks there at the end of August, early September, where people who were DC residents were getting their vaccinations in Maryland and Virginia. And then once we did this legislation and the pharmacies in DC opened up, that switched. We had consulted with Walgreens to make sure, and I'm sorry, with CVS to make sure that this would work for them and that they were aware of it and could turn things on as soon as it was in place. And so we saw exactly that. They are the major provider in the pharmacy world. And so right after that, the next week, they were the major provider in DC.
Okay.
We are a little behind on our elders compared to where we were last year. So we're looking at that.
So let me ask a couple of questions about that, actually. Well, let me start with the kids and then we'll get to the elders. So access to the COVID booster is still limited, particularly for children. Unfortunately, I believe our largest pediatric provider in the district still doesn't have it yet. And that some of the pharmacy chains, particularly the ones that are attached to grocery stores, do not do vaccinations for kids under 12. So are you all tracking this? And how are we ensuring that we do have that access for families?
So one, I will say the grocery chains are not a major provider in the city. They are a provider, but the vast majority are done by retail pharmacies, and they do vaccinate children under 12. The complication that happened with our pediatric providers was about the change from Pfizer to Moderna and not about their willingness or ability to do vaccination. So when Pfizer did not go forward with their early childhood vaccine, and the emergency use authorization wasn't there, it was pulled. And so people who had been doing Pfizer, and that was what was in their electronic health record, and that was what was in their process, had to switch over to Moderna. They've now done that, but it did add time to the process. So the delays from ACIP and then the need to make a big administrative change around what they are ordering and then stocking and able to document in their charts, it created a gap, but that gap is coming to an end.
Okay. All right. And I trust that that pediatric provider would provide appropriate notice once they have the vaccines in hand.
I believe they will.
Okay. I also understand that the at-home vaccine program, which was like super popular amongst our seniors, has been transferred from DC Health to Fire and EMS.
Yes.
Why did you all decide to make that change? And is DC Health monitoring the number of residents FEMS is serving this fall through that
So
program?
they're just starting.
Okay.
And we will be monitoring them.
Just starting as in October, or have they been going?
I believe it's October, but I can get a start date for you.
Okay.
It was really an administrative change. The COVID money that used to fund that ended. And so we were looking for a different funding mechanism, and it made more sense to use to leverage the existence of FEM's community community paramedic program that was already doing home visits and other things than to have a standalone program that sat alongside it. So it's an efficiency, and it helps us to get to different parts of the community.
I always like, let's not reinvent the wheel, but let's see who already has something going. I just would be interested to see in terms of the volume that FEMS gets, and also how do we alert seniors who had been using it with DC Health of the new phone number to be able to schedule
We'll
those
let you know
visits.
how
Okay,
we're moving that along.
great. Have there been any changes in the federal funding or administration for the Vaccines for Children program this year?
So no, and yes. So part of it's not entirely clear what's going to happen if ACIP makes further changes in the Vaccine for Children's program. The Vaccines for Children's program is tied to ACIP recommendations, and so we'll have to see what happens on that front. So we are looking forward to perhaps having to make some adjustments. In the meantime, we do still have VFC vaccines available for the full spectrum, and providers are ordering them.
Okay. We have only 3 more questions. I know you have
Okay.
an important RAT meeting to get to. Does DC Health took over the operations for the school health services program and the school-based health centers this year. Is DC Health administering vaccines through either of these programs yet?
So
or-
we are not, but we do mobile vaccine through at school sites. That is how we've done it for some years now. And it, I think, works a bit more efficiently than just having individual vaccine available that may or may not be used. So the most efficient way, which I think is what we're doing, is to gather who needs vaccine at a particular site as we're looking at kids who are not meeting all of the requirements and need to be caught up, and then have individual events at those locations.
Okay.
So it leverages the fact that we have facilities there and doesn't necessarily make that part of the duties of our on-site staff.
All right. Is there anything else you want to share with residents about DC's participation in the vaccine conversation?
So we have
Nationwide.
been part of every conceivable conversation that I can learn about. So I am, because DC is lots of things, I am part of the Big Cities Health Coalition. I'm part of the, I attend all of the state health officer meetings. I have been in communication with the other collaboratives that are starting up. And they're a little informal at the moment so we are in conversation with them, and we will participate in anything that looks like it's a benefit to the people of DC as soon as we determine that that's so. So right now, we don't have any real changes that we're making. We're looking forward and planning with folks, but we will be keeping abreast of what everyone's doing.
Okay. It's kind of interesting. The government shutdown might be helpful in this regard, in terms of decisions not necessarily being made from the CDC level when it comes to vaccines in the middle of RSV, flu season, et cetera.
Well, if they were planning to have a meeting, they were meant to do public notice quite some time ago. So it seems as if maybe they weren't going to
What are rules?
have the meeting.
What are public
expected.
rules? Nonetheless, I want to thank you again. And I want to just reiterate to folks, right? Vaccines are safe. They are
Yeah.
effective. Our pharmacists are great
Yeah.
public health individuals who are on the front lines of this work. And I'm sure the Board of Pharmacy would have been here if they were able to make it. And so we are trying to do this in a way to be proactive as
Mhm.
opposed to being reactive to whatever happens next in this conversation. But I want to thank you for being here and testifying this morning, and we're going to go on to our second bill.
Okay, thank you for bringing this issue forward.
Thank you. Okay, so now we're going to move on to the second bill today, which is Bill 26-0159, the PrEP DC Act of 2025. This bill was introduced on February 28th, 2025 by Councilmember Parker, along with myself, Council members Louis George, Pinto, Nadeau, Allen, Bonds, Robert White, and Felder. It was jointly referred to the Committee on Health as well as the Committee on Business and Economic Development. This bill would prohibit health benefit plans and health insurers from using prescription information as a condition of eligibility or to set premium rates. It would also prohibit insurers from restricting or imposing delays on the distribution of antiretroviral prescription drugs prescribed to a person for the treatment or prevention of HIV or AIDS. Finally, it would prohibit health insurers from imposing any cost sharing for HIV prevention treatment, such as the drugs used for pre and post exposure prophylaxis known as PrEP and PEP, which are used to prevent new cases of HIV. Last year, the district achieved a very important milestone in our fight against HIV. DC Health reported 192 new cases. For the first time, for the first time, we have less than 200 new cases annually since the 1990s, which is huge. We also have a higher rate of PrEP prescriptions for individuals at high risk of HIV exposure in the district at almost 60% compared with 36% nationally. We celebrate these achievements while knowing that there's still much more work to be done. There are approximately 11,670 district residents living with HIV, which is highest concentrations in wards 5, 7, and 8. Young people 20 to 29 years old and Black men and women are experiencing new HIV cases at a disproportionately high rates compared to the general district population. In the face of federal funding cuts for critical HIV prevention and treatment programs, it's more important than ever to use every available tool to prevent new cases of HIV and decreasing costs and protecting patients, this bill is one such tool that could help increase critical access to the drugs and prevent new cases. We have been joined by Councilmember Zachary Parker from Ward 5, who is the author of this bill. Councilmember Parker, if you want to give an opening statement, you have 5 minutes.
If you give me like 10 seconds.
Oh, okay. Councilmember Parker from Ward 5.
Yes, thank you. And of course, my computer is crashing, but I will say this. I was proud to introduce this legislation to contribute to the district's fight against HIV and AIDS rates. Since coming on a council, I've been very proud to be a part of this committee and contribute to its work. And I've been laser focused about how do we double down on the great work that has been going on for a long time, led by DC Health. I think in part, this legislation accomplishes 3 things, or seeks to accomplish 3 things. One, it ensures that insurers and health plans don't use prescription information against patients and inform or increase premiums as a result. And it ensures that insurers don't delay the distribution of antiretroviral medications for those in need. And it eliminates copays and heightened premiums on PrEP and other life-saving medications. I tuned in to the previous discussion around vaccines and access, and I very much see this as part of a continuum of work that this committee and the council is leading in partnership with DC Health to ensure that residents have a robust suite of resources that we can continue driving down sickness and illness and disease. I'll end on this, and it's a shout out and a praise for DC Health. And you gave those stats about, I believe last year it was, that we saw HIV infection rates reach a 30-year low. That is significant. And the context in which we find ourselves now is that the district, like many other jurisdictions, are seeing support and funding from the federal government slashed. And it's going to be even more important for us to double down locally on strategies to ensure that we get as much or as many resources out to residents as possible. So I'll end there. I'm looking forward to the testimony and moving this legislation forward. Thank you.
Thank you. All right. So I have 6 witnesses, so we're just going to call everybody. Andrew Barnett, who's a psychologist, HIV Prevention Treatment Services at Children's National Hospital. Salim Adolfo, ANC Commissioner, Ward 8. Don't see Salim. Maurice McCants-Pearsall. Okay. Thomas Glassick from the DC Insurance Federation. And then virtually, we have Carl Schmid, who's the Executive Director of the HIV plus Hepatitis Policy Institute, and Juan Carlos Lubriel from Whitman Walker Health. All right. If you're joining us virtually, again, you have to affirmatively accept our invitation to become a panelist. So there's going to be a little box that pops up on your screen and just say, yes, I'd like to convert. All right. Dr. Barnett, when you're ready.
Good morning, Chairperson Henderson.
Oh, wait, Dr. Barnett, you got to move the mic.
Gosh,
Lean in.
I thought I had a loud voice.
There we go.
All right. Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Dr. Andrew Barnett, and I'm a pediatric psychologist in the HIV Prevention and Treatment Service at Children's National Hospital. Children's National has been serving the nation's capital since 1870 and is proud to be named among the top 10 children's hospitals by U.S. News and World Report Best Children's Hospitals. Thank you for the opportunity to provide testimony on B26-0159, the PrEP DC Act of 2025. As you may know, adolescents and young adults are among the highest at risk for HIV transmission. In the District of Columbia, the rate of new HIV diagnoses each year is more than twice the national average, and 23% of new infections in the district occur among young people ages 13 to 24. While the district has made remarkable progress in HIV prevention, this data is a reminder that our work is not done, particularly when it comes to reaching and protecting our young people. At Children's National, our HIV prevention and treatment services team provides PrEP and early intervention services to adolescents and young adults at risk for HIV as part of our Ryan White grant-funded program. We engage in targeted follow-up with youth who present to the Children's National Emergency Department for STI testing and treatment and offer red carpet concierge services for new PrEP patients, which includes rapid linkage to a first appointment. Our wraparound care model includes not only expert medical care, but also case management and mental health services to help youth stay connected to PrEP services. Unfortunately, even with our enhanced level of care, we have seen how insurance-related barriers to PrEP can prevent youth from accessing these vital, effective medications. We know that when prevention services are accessible, affordable, and stigma-free, youth are eager to engage in healthcare and take proactive steps to protect themselves. Children's National strongly supports B26-0159, the PrEP DC Act of 2025, because it will reduce insurance and cost-related barriers and expand access to PrEP for youth and young adults. More broadly, the provisions in this bill can help prevent new HIV infections in our communities and advance the district's goal of ending the HIV epidemic. Thank you for the opportunity to testify on this important legislation, and I'm happy to answer any questions you may have.
Thank you. Mr. McCants, Purcell.
Good morning, Chair Henderson, members of the Committee on Health and staff. My name is Jay Maurice McCants-Pearsall. I'm the Director of Government Relations at ViiV Healthcare. We are the only pharmaceutical company solely focused on developing HIV prevention and treatment therapies. Thank you for the opportunity to testify today in strong support of B26-0159, the DC PrEP Act of 2025, and to offer some recommendations for minor clarifying amendments to the bill. As previously mentioned, the DC CARE Act focuses on removing barriers to HIV prevention services. These are practical and target fixes that directly support the goals outlined in the most recent DC Integrated HIV Prevention and Care Plan. Due to the Affordable Care Act, federal law already requires payers to cover grade A services, including PrEP, without cost sharing and other restrictions. Last summer, there was a decision before United States Supreme Court that would have ended those safeguards. The court ultimately upheld ACA preventative care, but that threat shows that there's still more work to do and why local matters and why local actions matters. Enacting this legislation will backstop federal protections and ensure that most DC residents have unmitigated access to PrEP, regardless of ongoing federal litigation or policy shifts, and will keep clinical decisions where they belong, between the patient and the prescriber. To help the agencies and payers implement the law, we recommend the committee consider making the following clarifying amendments. First, we recommend the committee add a definition for medically unnecessary restrictions or delays. That definition should include prior authorization, step therapy, and other utilization management administrative practices that delay access to PrEP medicines. Second, in Section 4, subparagraph A, we recommend that the committee require that health plans cover all preventative treatments approved by the FDA. And finally, in Section 4, subparagraph A and C, we recommend that the committee clearly clarify that in addition to requiring coverage for baseline assessments without cost sharing, health plans should also cover any laboratory services, diagnostic procedures, clinical follow-ups, and monitoring, and any other related services. These clarifying amendments are consistent with the bill's purpose and mirror best practices in other jurisdictions that have protected access to PrEP. In closing, the DC PrEP Act is a focused and evidence-aligned bill that will protect patient privacy and access and will help end the HIV epidemic. I urge the council to advance the DC PrEP Act of 2025 with these minor revisions. Thank you for your leadership and the opportunity to testify.
Thank you. Mr. Glassick.
Thank you, Madam Chair. My name is Tom Glassick. I'm the Executive Director of the DC Insurance Federation, and I believe that this is the first time in my tenure of 3 years that I've been before your committee. So thank you for including me, kind of last minute. I am, like I said, the DC Insurance Federation has some thoughts about the bill, nothing significant. Well, certainly significant, but nothing major. What I do want to make clear is that health plans in the District of Columbia are already taking care of PrEP and PEP. Everyone completely supports this legislation. However, we're concerned that there's some interplay between, not concerned, we note some interplay between the ACA requirements and the way the legislation is written, most particularly in Section 4C, the reference to or in setting premium rates. I noted that DISB has a comment about the same section, and we've been working with them, and we would continue to. We believe the cleanest thing to do would be just take out that phrase. That does not mean it'll change anyone's premiums. It means that all PrEP costs go into the process of setting premiums. So it's not as though someone taking PrEP or PEP would have a difference in premium. It's just when the actuaries are building premium rates for the categories involved, they would be able to include this. So the cost would appear in premiums rather than not being included. There are only 4 reasons why you can discriminate or change premiums, and that is the use of tobacco, the rating area, family size, and age. So those are the only places that health insurers can alter premiums, and this doesn't fit into those categories, so there would be no need to. I will be getting you written testimony, as you noted. It was not there last night, and I'm happy to answer any questions that you have.
Thank you. Mr. Schmid, who's online?
Good morning. My name is Carl Schmid. I've been a resident of the district for over 40 years and been involved in AIDS activism for over 30 years, getting my start here in DC. I'm now the executive director of the HIV and Hepatitis Policy Institute. Today, we voice our strong support of the DC PrEP Act of 2025, introduced by Councilmember Parker. In order to continue to reduce the number of HIV infections, DC must do everything possible to ensure we have for the people who have a reason to protect themselves against HIV have access to all prevention tools. That includes PrEP. While the ACA requires people with private insurance to have access to no-cost preventive services, including PrEP, due to its favorable recommendations by the U.S. Preventive Service Task Force, serious legal challenges to this requirement have recently made their way to the Supreme Court. While we won, the court clarified that the HSS secretary has considerable authority over the task force, its recommendations, and insurance coverage requirements. Unfortunately, the secretary has canceled 2 scheduled meetings of the task force, and its future is unknown. In order to protect the coverage requirements, it is important for states to take the steps on their own. We commend the bill's authors for pursuing robust safeguards for DC. However, instead of relying on coverage of PrEP drugs included in CDC guidelines, since the work of the CDC and its HIV division are in doubt as well, we recommend that the bill just require coverage of all FDA-approved PrEP drugs. Another reason to pass the bill is due to the rapid evolution of PrEP drugs. The U.S. Preventive Service Task Force and federal guidelines cannot possibly issue an update every time a new drug is approved, nor should they. Soon we may have a once every 4 month or once a year injectable or maybe a once a month oral. Without the insurance requirement, payers will look for ways not to cover the most recent advancements. Prevention works when people have options. Another access barrier to PrEP has been prioritization requirements. While the federal government has issued guidance saying that not allowed, it's important for states to include this prohibition in their laws. Despite federal requirements, studies have shown that 1/3 of PrEP users still face cost sharing. For years, we've heard of PrEP users in DC facing copays and prioritizations. Therefore, we urge you to ensure that the Department of Insurance make sure insurers are in compliance and quickly respond and resolve complaints. When it comes to PrEP, people cannot risk delays in access. We do have some additional suggested changes. They're very minor. We've included them in our testimony. But I want to end that DC should be applauded for the advancements it's made in reducing HIV. In order to continue that progress, we strongly urge the council to pass this bill. Thank you.
Thank you. Mr. Lubrell.
Good morning.
Good morning.
Dear Committee on Health and Chairperson Henderson. My name is Juan Carlos Lubriel, and I have been working in HIV prevention and care since 2000, both here in Washington, D.C. and back home in Puerto Rico. I serve as the Senior Director of Community Health and Wellness at Women Walker Health, our overseeing our prevention and education efforts, PrEP navigation, PrEP clinic, and wellness programs. Whitman Walker Health is pleased to submit comments in support of B26-0159, the PrEP DC Act. We support requiring coverage for oral and injectable PrEP, including related services, without delays, barriers, or cost sharing for insured people in the District of Columbia. Whitman Walker Health is a federally qualified health center serving DC's diverse community, including those who face barriers to care. We have been nationally recognized leader in community health for nearly 4 decades. In 2024, we provided care to more than 19,000 patients. Whitman Walker has long been a national leader in HIV treatment and prevention. In 2024, we provided care to 3,806 people living with HIV, about 21% of DC's HIV positive population. 86% of our patients living with HIV are virally suppressed. Early program data show even higher suppression rates among patients using injectable ARTs. In 2024, we provided 8,960 rapid HIV tests. 3,885 patients received a PrEP prescription. And since ongoing in 2018, our innovative PrEP clinic has served over 2,100 patients, many receiving PrEP within an hour. Whitman Walker strongly supports requiring insurers to provide comprehensive PrEP coverage without delays, cost sharing, or restricted practices. We support prohibiting the use of prescription information for discriminatory purposes, preventing insurers from designing plans that disadvantage PrEP users. We also support preventing restrictions such as prior authorization or step therapy for PrEP or ARTs, which delays access to essential medications. And we further support prohibiting cost-sharing requirements for PrEP and PEP medications and related provided administered services. And we recommend including coverage for ongoing monitoring screening, not just baseline assessment, to align with CDC and USPSTF guidelines. And we appreciate the Council's work to improve access to PrEP and PEP, and we look forward to working together to ensure effective implementation. Thank you for your time.
Thank you. Ashley, if you could do a 7-minute round for our public witnesses. All right. Thank you all so much for being here and for the testimony that you provided. I do have a couple of follow-up questions. Dr. Barnett, you mentioned in your testimony around the new cases among young people 13 to 24. What do you, I guess, attribute that to in terms of the rise there? Is it the lack of messaging around prevention protection? What can we be doing better with that particular age group?
That's a really good question. And I wish I had a simple answer to it. Youth have been disproportionately impacted by the HIV epidemic in DC for some time. I know that in our program, we provide care to youth living with HIV as well as prevention services to youth at risk for HIV. And there have been times when we see youth who are coming in newly diagnosed with HIV who are younger than the age of the youth on average who are coming to us for PrEP care. In terms of what's driving that, it can be lack of access to education about safer sex and prevention, as well as adolescents sometimes are not as aware of their risk as older individuals. But I know that I'm punting. I think that it's a really great question, and we're still trying to figure that out.
No, I mean, I wouldn't expect you to sort of know all the answers, but I'm just so curious in terms of, right, it's 2025, in terms of access to information, 13, 14-year-olds have it way better in terms of being able to seek out information from a privacy standpoint. So like your parents wouldn't necessarily find out that you're asking these questions. And so it would seem as though, and I don't know, it could be sort of naive, is that like when you have that access to information to be able to ask questions in a safe and secure environment, that you would have more, less cases because more folks are seeking out prevention techniques. But
yeah, and I think that really goes to the importance of protecting access to preventive care for youth and adolescents.
yeah. So a number of you actually talked about amending the legislation so that it covers all FDA approved prevention drugs. I guess that allows for it to be proactive and sort of recognizing that there might be innovations and things like that in the future. Do you have any concerns about the reliance on the FDA in that regard?
I guess I could answer that. Well, first of all, to back up in why we just don't want to rely on the CDC as the bill is written. And as I said in my testimony, that the CDC, we don't know its future. And right now, that the U.S. House of Representatives has proposed to delete all funding for HIV prevention at the CDC. And those are the people that put out the guidelines and the recommendations. So, in the past, I think we would have relied on the CDC, and we still do. But to be safe, I think we need to rely on the FDA. You have to, for any drug to be used in the United States, it has to go through the FDA. So we wouldn't have access PrEP users to even recommend or access a PrEP drug without FDA approval. So I do think we have to trust them.
No, I mean, I want to trust. I do want to trust. And I think someone said in an earlier panel, right? FDA approvals is all about safety. That's with an asterisk, right? I remember in college, I wrote a paper about the politics of Plan B and the process of the FDA approving Plan B over-the-counter use. That was a political process. It was not one based that was on the science, which can happen, certainly, right? That influence is there, and we hope that it's not. But I just wanted to be clear in terms of like I know we're kind of picking among the people, the institutions right now, but not all institutions are immune from political influence, particularly when it comes to this issue. Dr. Barnett, one other follow-up. You said that currently you all are providing the PrEP access through Ryan White funding. What happens if Ryan White goes away?
That is a question that I would have to defer to others, like leadership within the hospital, to answer.
Okay.
I know that right now we're able to provide really excellent, high quality early intervention services because of that grant funding.
Okay. I think to the Mr. Schmidt's point, I think all of us are having to think through what does access look like and options when you cannot rely on the federal government in that regard. And so I think we all have to sort of be a bit more creative in some of our thinking around those things. Mr. McCants, Persall, thank you so much for the recommendations that you made. You included this in your written testimony?
I did.
Okay, because you have some specifics around definitions and otherwise, and we want to make sure that we can take a look at some of those things.
Correct.
Now, the issue of prior authorization, this came up in Mr. Schmidt's testimony, as well as some other folks brought this up as well. We did prior authorization reform in the district already. It's law now. And we know that there are some things that can still kind of get hicked up in the process, but we don't know to ask the questions or know to check in with DSB if folks are not letting us know. Now, what is considered a medically necessary delay?
That's a good question. There shouldn't be any medically necessary delays, right? A person who is seeking PrEP should be able to go to their provider, go through the requirements that are required for PrEP, right? HIV testing, suppressed viral load. If that person does qualify and they do have insurance, then they should be able to, the prescriber should be able to then put the prescription in, and that person should be able to get the medication without having to deal with prior authorizations or any unforeseen delays. So I'm not sure if that answers your question.
Yeah. Okay. No, that did.
It should be a very straightforward process. If a patient is able, they meet the qualifications and requirements for the medication, they should be able to have access to it without any hindrance or barriers from the insurance company.
Okay. Mr. Glassick, thank you so much for being here, representing the insurance folks. when you just send over your written testimony, and we'll certainly take a look at some of the suggestions.
Yes.
We feel like we have a product that we can move forward, that makes sense. Especially since most of our insurance companies are already providing this type of coverage. And so, we just want to ensure that everyone coming into our marketplace knows what our standards are. Mr. Parker.
Thank you. Mr. Barnett, how have insurance barriers presented themselves for younger patients that you're seeing?
So we've been fortunate at Children's National because we have these really excellent wraparound care model that we have not seen that prevent youth from accessing PrEP. But we know that in terms of the research, that insurance barriers can be a major reason why younger populations don't have access to PrEP or stop PrEP.
Got it. Got it. And then you had mentioned in your testimony the red carpet concierge service. I think I know what that means, but what does that mean in terms of PrEP access?
So in terms of PrEP access, I think one of the most important things that it means is that when we get a referral for a patient who would like to start PrEP, that we connect with them quickly, that we offer them a first appointment very quickly. Our goal is within 72 hours so that they can get access to care and get started without delay.
And I'm assuming, given the population you're talking about, parental approval is necessary.
So that is a good question, and I would defer to my medical colleagues on that. I know my understanding is that in the district, youth are able to access sexual and reproductive health services after a certain age without parental involvement. I know that many of the patients that we work with have their parents are coming to their appointments with them and strongly support their children being protected from HIV.
Understood. Thank you. Mr. McCants-Persall, thank you for your testimony and the recommendations.
Thank you.
You know, I think the delay recommendation is one anecdotally that I have heard friends and others discuss, that their doctor is saying, take this medication first before we prescribe this, or let's wait and see what happens before we move to this. And it's something, to your point, that we should be moving away from. The USPSTF, or the U.S. Preventative Service Task Force, has guidance on PrEP administration. In your organization's work on these matters, how have you seen states take up that guidance or implement it?
For example, there are 2 states that have taken the United States Preventative Task Force language and codified it into law, which is what we're trying to get done here in DC. Those states are Illinois and Washington State. When people have access to, what we're seeing is people who are eligible for PrEP are being denied, right? And there's a host and list of reasons why.
What are some of those reasons, anecdotally, that you're hearing?
To your point, some providers have said that, well, you have to have an oral lead-in, right, to the medications. For some, in the early days of long-acting injectables, there were oral lead-in. However, those guidelines have kind of changed in many ways, where if a person is virally suppressed, they don't necessarily always need an oral lead-in. Now, I may be speaking
about oral lead-in, you mean taking pills versus getting an injection?
Well, taking it to prior to the administration of the actual injection, right? It's kind of the lead up to that medication. In addition to being virally suppressed for said period of time prior to being able to be administered the long-acting injectable. Those are some of the things that we, some of the things that we've seen along the way. But yeah, again, it's important for us to make sure that we codify this language because we want to make sure that we are eliminating as many barriers as possible.
Absolutely.
For folks, because we know that if a person is particularly on PrEP medication, that they are at less risk for acquiring HIV, right?
Yes.
Which speaks to what we're trying to do in the integrated plan within DC.
Understood. Thank you. Thank you. Mr. Schmidt, I wanted to come to you. You mentioned in your testimony that PrEP users are being charged cost sharing and are subject to prior authorizations by insurance and DC. Can you explain what you've been hearing and what can be done to overcome some of these barriers? I know you mentioned some in your testimony, but if you could elaborate, that would be helpful.
Yeah, and by passing this bill, I think is one way of making sure. But what we're hearing, particularly with the long acting, is people are going through prioritizations, and that's a delay. And I'm sure the Whitman Walker witness could attest to this. They have staff that works with the insurers, and it takes time. And it shouldn't be that difficult to get PrEP. And someone wants to protect themselves against HIV. And then, we're also seeing cost sharing too. And that's the whole, as we said, this is already supposed to be happening, but the insurers sometimes are charging cost sharing. And patients don't know that they're supposed to be getting this for free. They may be walking away because they have $100 copay, or for their next, lab test as well. That's supposed to be free as well. And I think, by passing this bill and then proper enforcement and quick action by the Department of Insurance is helpful. And, they could do conduct exams by the insurers. But I think, we just can't rely on patients complaining because they don't even know that they can complain.
Absolutely. No, thank you. And I'm running out of time, but Mr. Labril, can you just describe what is the average turnaround that you're seeing at Whitman Walker?
So for injectable PrEP has been a quite long time now. Early data show us that folks who are an injectable PrEP have a better adherence retention. So this has been from 7 to 15 days delays to get those medications approved, and require extensive work behind the scenes. So it requires a personnel, dedicated staff to make those calls, to go through those prior authorizations, to negotiate, to send those letters to the insurers. So it's been sometimes a big delay, and it delays the entry point in the PrEP care continuum for our patients.
That's helpful. And in my last 10 seconds, I would just say 15 days delays on top of everything else could make a big difference in the health outcomes of an individual. And I'll end here with just these stats again. The reason why this is important is because we want all district residents to have access to these life-saving medications, but we also know that 11,000 residents are living with HIV, and some of the highest concentrations, not surprisingly, are individuals living in wards 5, 7, and 8. Young people aged 18 to 24 represented 22%, nearly a quarter of all newly diagnosed infections. And so we have a bit of work to do. And I think your testimony today will help us move the needle. So thank you.
Thank you. Thank you all for being here. And just again, please make sure you provide your written testimony for the record. Okay, we're going to now turn to our government witnesses. Philip Barlow, who's the Associate Commissioner for Insurance at the Department of Insurance, Securities and Banking, and Clover Barnes, who is the Senior Deputy Director of HIV/AIDS, Hepatitis, STD, and TB Administration, also known as HOSTA, at DC Health. Okay, before you begin, I have to swear you in because Councilmember Parker made this a rule. So if you could raise your right hand. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. All right. I don't know who wants to go first. It's up to you. All right, Commissioner.
Thank you. Good morning, Chairperson Henderson, committee members, staff, and district residents. I am Philip Barlow, Associate Commissioner for the Department of Insurance, Securities, and Banking, also known as DISB. I have trouble saying DISB, but so I will call it DISB. I appreciate the opportunity to testify today on Bill 26-0159, the PrEP Act of DC Act of 2025. At DISB, we regulate the insurance, securities, banking, and other financial services entities doing business in the District of Columbia. Our mission is threefold: to cultivate a regulatory environment that protects consumers and attracts and retains financial service firms. Second, to empower and educate residents on financial matters. And third, to provide financing for small businesses. We accomplish this by regulating the district's financial services industry, including health insurance companies, to ensure the district residents have access to a wide variety of financial services products and providers. Bill 26-0159 aims to prohibit health plans and insurers from using prescription information as a condition of eligibility or in setting premium rates, to prevent insurers from restricting or delaying the distribution of antiretroviral drugs prescribed for the treatment and prevention of HIV or AIDS, and to bar insurers from imposing cost-sharing requirements such as deductibles, coinsurance, or copayments for pre-exposure prophylaxis and post-exposure prophylaxis used to treat HIV infection. From a public health perspective, the department is supportive of efforts to increase access to and promote the use of PrEP and PrEP. To that end, I have a few key points to make about the bill today. PrEP is covered under the Affordable Care Act as preventive care. However, PrEP is considered an emergency treatment and must be started within 72 hours of possible exposure to HIV. Although PrEP for emergency use as a preventive measure to reduce the likelihood of HIV infection, insurers generally cover it with low or no cost sharing in most plans, like they would for other preventive services. Since plans already cover both PrEP and PEP, we suggest alternative language where Section 4 does not say each plan must cover PrEP and PEP, but could instead say if PrEP and PEP is covered, it should be covered without cost sharing and coverage no more restrictive than other treatments to avoid unintended impacts on the district. Section 4C could be rephrased, instead of saying setting premium rates, to wording such as underwriting rate-making criteria, which is consistent with language in DC Code 31-3311-03B. The council may want to consider incorporating Bill 26-101, the Removing Barriers and Reducing Stigma to Encourage HIV Prevention Amendment Act, introduced by Councilmember Pinto, with this bill, since they have similar aims. That bill has been introduced twice before and would prohibit insurance companies from factoring the use of PrEP in decisions related to the issuance of disability, life, or long-term care insurance policies. The department supports the bill and its goals to increase access to promote the use of PEP and PrEP. We encourage considerations of the issues we highlighted in our testimony. If you have any questions, please contact Commissioner Woods or myself. We urge the council to take favorable action on this bill after considering the modifications discussed. I appreciate the opportunity to share the department's feedback and welcome your questions.
Thank you. Ms. Barnes.
Good morning, Councilperson Henderson, council members, the Committee on Health staff. My name is Clover Barnes. I am the Senior Deputy Director of DC Health's HIV/AIDS, Hepatitis, STD, and Tuberculosis Administration, affectionately called HOSTA. On behalf of Mayor Muriel Bowser, I am here to provide testimony in support of the PrEP DC Act of 2025. This legislation is aligned with DC Health's goal of ending the HIV epidemic in the district. It would reduce financial and health insurance barriers for biomedical HIV prevention treatment, something that can prevent patient access to these important medications. The legislation will reduce these barriers by prohibiting health insurance from imposing any cost sharing or administrative delays on people seeking access to those medications, and from using a patient's use of HIV prevention medication as grounds to alter policy eligibility or premium. The district has made significant strides in addressing the ongoing HIV epidemic, including a 51% reduction in new HIV diagnoses between 2016 and 2023. A key tool in continuing this success is the availability of effective biomedical HIV prevention treatment options, including pre-exposure prophylaxis, or PrEP, and post-exposure prophylaxis, or PEP. PrEP is medication for people who are at risk of HIV to reduce the risk of transmission. It is administered either through a daily pill or long-acting injectable taken every 2 or 6 months. PEP is used to prevent the transmission of HIV after a possible exposure. People who may have been exposed to HIV must start PrEP medication within 72 hours of the exposure and then take the daily dose for 28 days. Both PrEP and PEP are highly effective at reducing the spread of HIV. PrEP has an efficacy rate of 99% for transmission through sexual contact and 74% through transmission for injection drug use. And PEP reduces HIV infection by 81%. Given their effectiveness, DC Health fully supports efforts to increase their access. Together, PrEP and PEP are a core strategy in DC Health's effort to eliminate HIV transmission. HOSTA's DC Health and Wellness Center provides PrEP care to patients initiating their PrEP treatment and continues to provide access until patients are linked with a long-term provider. On average, the clinic supports patients for approximately 12 to 18 months. And as of earlier this month, 650 patients access PrEP through the clinic. In early 2021, DC Health launched its PEP hotline, a 24-hour phone service that ensures people who have an HIV exposure can get access to a PEP prescription within 72 hours. In calendar year 2024, the PEP hotline received 404 calls, of which 322 people were prescribed PEP. This hotline is also an effective mechanism to connect people with PrEP for long-term prevention. DC Health has also connected hundreds of patients with pharmaceutical patient assistance programs, which are administered by pharmaceutical manufacturers to provide medications or financial assistance to patients who face barriers to access. This involves DC Health staff completing applications, navigating the application process, and ensuring the person is successful in receiving their PrEP medication. These efforts and others by DC Health and its partners continue to promote awareness of these medications, educate district residents and visitors about their efficacy in stopping the spread of HIV, and increase access points. As of 2023, 53.2% of the people in the district who are at high risk for HIV transmission have been prescribed PrEP, a rate that is almost double what it was in 2017. While the main barriers to increased HIV prevention medication uptake are lack of awareness and social stigma, DC Health recognizes that financial barriers can present a serious obstacle to treatment, and this legislation helps address the financial challenges. DC Health supports the intent of this legislation to promote affordable access to HIV prevention medication. I thank you for providing me with the opportunity to testify, and I'm available to respond to any questions the committee may have.
Thank you. Thank you guys for your testimony. There's another hearing going on right now, right across the hall. So Councilmember Parker is there now. He's coming back. So I'm just going to go until he gets back, and then we'll see how far we get. All right. So this question is for you, Director Barnes. How frequently do patients at the DC Health and Wellness Center have cost sharing requirements for the drugs for PrEP and PEP through their insurance?
So typically at the Health and Wellness Center, if a patient has cost sharing issues, that's where we access the pharmaceutical assistance programs.
Okay.
We use those fairly often. A lot of times the costs can be prohibitive for patients. Sometimes it's not just not the medication, but it's the labs, it's the other things that go along with it. Because you have to have certain labs and certain tests in order to be prescribed PrEP.
Okay. Do you see patients who are paying out of pocket because they're concerned about insurance rates going up?
Not at this moment. We have been very successful in using the pharmaceutical manufacturers programs.
Okay. Without insurance, how much typically does PrEP run?
It depends on the medication.
Okay.
Because the different medications have different costs, but out of pocket cash, it could be a significant cost.
What's significant? Because today in America, significant can be $50. So like what's
Yeah.
significant?
So a generic is fairly cheap. If you take a generic pill, that's fairly cost efficient. The long-acting injectable can be hundreds, maybe $1,000.
$1,000. Okay.
That's an estimate.
Okay. Commissioner Barlow, I understand that PrEP is covered with no cost sharing on most of DC's health insurance plans since it's considered a grade A recommendation. of the U.S. Preventative Services Task Force. Are there any plans in DC that don't currently cover it?
So we reached out to all the carriers offering major medical insurance plans in the district that we regulate, and found they were all covering it.
Okay. Which makes sense because covering a prevention is much cheaper than covering the treatment thereafter. Um, let's say, for instance, the U.S. Preventative Services Task Force recommendation were to change. I don't want it to change, but things are weird, as you know. Would the bill's current language still ensure that PrEP is covered?
So the bill's language, yes, I think the bill's language would continue to require coverage for PrEP. But again, I think the bulletin that we issued related to the previous bill should also help to require insurers to continue to cover PrEP because it was a identified preventive service as of 12/31/2024.
Okay. Would it be more robust for the bill to guarantee no cost sharing for all FDA approved PrEP drugs?
I don't know that. I mean, I think that's sort of a belt and suspenders kind of thing. I would imagine that just by as long as it requires coverage of PrEP, as long as the treatment is identified as PrEP, then it should be covered. But I don't think there's any harm in identifying the treatments, saying any treatment for the coverage of PrEP.
Okay. I know you guys asked what plans were covering it. Did you also go as far as to ask who requires cost sharing?
Well, again, there shouldn't be any cost sharing for PrEP because of its status as a USPS TF type A recommendation. So
Okay.
I don't,
Well, what about PEP, which is a little bit different?
so PEP, we understand that some company, I mean, again, for PEP, when we asked whether they covered it, yes, they did, because again, as you said, it makes sense that they would cover PEP, even though it's not, even though it's not technically a preventive service under the USPSTF process. But so they did cover it, but some of them did indicate that they covered that there was cost sharing, and I don't know that we specifically asked about prior authorization, but there could have been that.
Okay. Is it possible that you could follow up with the committee to tell us how many have cost sharing? You don't need to disclose which ones. I know that they might feel sensitive about that, although some of them have disclosed themselves to us. But we're just trying to get an idea of how many do as we sort of build out.
Sure, we will try to, and of course they have many plans. They may have some with and some without. So we'll try to get you a sense of what the coverage is with and without cost sharing.
Okay. The RX guide indicates that several plans do not cover doxypep or doxysaline. Does that mean that those plans don't cover PEP treatment at all, or just that specific drug?
So so our RX guides are general guides that we use to help residents of the District of Columbia when identifying what health plan that they want to use as to what kind of treatments that what they can look up their drug and see how it's treated by the various insurance companies. The coverage questions can be a lot more nuanced than we can put into our little guide. But if it's so, but I don't, generally speaking, insurance companies don't have to cover every treatment for every condition. I think they just have to cover sufficient treatments for coverage. So it's very likely, I mean, we'd have to check to see, but I don't think there are any insurance companies who are not covering PEP, but they may be directing them towards different medications than the one that you mentioned.
Okay. We heard some public testimony about insurers using prior authorization as a way to restrict access to these drugs. I think the insurance company would call it resource management, but all right, restrict access. Has Disney received any complaints about delays in prior authorization for these drugs?
So I checked with our complaint staff after hearing the testimony this morning, and they, off of the top of their heads, they did not identify any recent complaints that we have had about that issue. But as Mr. Schmidt said, while complaints are a good indicator of where there might be a problem, the lack of complaints should not be taken as an indication that there are no problems. So
Right.
we can look into that to see if what we can find out about how prior authorizations are used in these medications or these treatments, to see if that is an issue.
Okay. The bill as introduced also includes language that essentially says that an insurance company can't use someone using specific prescription drugs as a reason to increase their overall premium, just as in like a you particular or you individual. Are you aware of any health benefit plans that currently do this practice?
So, under the Affordable Care Act, individual and small group plans don't underwrite, except as Mr. Glassick mentioned, some things that they can distinguish, like age and smoking status and
Right.
some things like that. So they do not. They do not have the option of considering whether somebody is PEP or PrEP. Large group plans do not have that same restriction. So while it's possible that that could happen, I think it's highly unlikely that a member of a large group having gotten PEP or PrEP would cause an insurance company to rate the employer or the group higher. But again, that's something that we can try to look at, but that's a harder thing to figure out. But I would think that, again, the benefit of covering PrEP, is known to the insurance company. So I think they would want to cover it. So, I don't think they would do that, but
We are in
yeah.
like I said, things are weird. Okay, so this question is for both of you. So Commissioner Barlow, you testified that the council should consider incorporating the language of Bill 26-101, the Removing Barriers and Reducing Stigma to Encourage HIV Prevention Amendment Act, into this bill. For those unfamiliar, the bill would prohibit insurers from factoring the use of PrEP in decisions related to the issuance of disability, life, or long-term care insurance policies. So it's different than healthcare. This is dealing with life insurance, but still there is the overlap that is attached to this. How common, well, have you all had instances of individuals being denied coverage or charged a higher premium for that type of insurance because of their use of PrEP?
Once again, we have not seen any insurance complaints in the district where that has been raised as an issue. But we have seen anecdotal reports from other states where they have run across that as an issue. So, I think there was a number of press articles about it a few years ago, probably prompting the initial issuance of the
bill.
The bill.
Yeah.
But we haven't really seen it recently. We haven't seen any more, or at least I haven't seen any more notices of that. But again, as as I say way too often, the lack of complaints does not mean there's not a problem. So, I don't think
Yeah.
it's a big problem, but there might be some issues that need to be addressed.
Okay. Would DC Health be opposed to incorporating the language?
No.
All right. Ms. Barnes, how has the changing landscape on the federal side in terms of federal funding for HIV prevention and treatment affected PrEP or PrEP access? here in the district for residents?
So we have a reduction of HIV prevention programming in the district because of a reduction in federal funding that happened last year. So that has reduced the connections through community-based organizations and our partners, FQHCs, that could happen. To try to combat it, we have worked to try to have them more interconnected and have them work together in better partnership and have our PrEP coordinator and our PrEP navigators more active in the community. So we have a new program called, it's not that new, but it's newer, called the Intervention Services Program, where we embed community health workers, nurses, and social workers into private practices around the district, as well as FQHCs and hospital-based clinics to help connect people to services more efficiently with the reduction in federal funding.
Okay. Are there any insurance barriers to covering drugs for HIV treatment that we should consider when moving this bill?
I'm going to defer to my DISB colleague for the insurance question.
So, I'm not aware of any. Again, I think we have RX guide that identifies what's available for coverage. So, but we have not heard problems with that.
Okay. I know it says 5 minutes left, but I've run my course on my questions. So Councilmember Parker.
Thank you. Thank you both for being here. We're tag teaming between hearings. So if you see us running in and out, that's what's happening as there are important matters happening across the council. Mr. Barlow, I'm going to start with you. District health plans annually determine the treatments they'll cover as part of those plans, as well as premiums, et cetera. Can you speak to the timelines that the district has with various health plans?
So, the where there's the most specificity is under plans covered by the Affordable Care Act, the individual and small group health plans. Those plans, the individual plans run January to December of the calendar year. Small group plans run they run monthly during the year, but the insurance companies are required under the ACA to get approval for the whole year's worth of rates
And that approval happens
to the beginning of the year. So,
and that approval happens around when?
So the insurance companies, we establish when the insurance companies are required to file their rates and forms with us for the future policy years. So in the district, we require the insurance companies to file the rates for, like, the rates for 2027 would be filed with us typically on May 1st of 2026.
Understood. So if this bill were to go into effect, and I'm thinking more about PrEP, because what I'm hearing from you is many of the plans have policies or coverage for PrEP, although we've heard testimony and anecdotally I hear about delays even with that coverage. It seems like there's less expansive coverage for PrEP that this bill also tries to cover. Should this bill go into effect, we're looking at health plan coverage for the year 2027.
I think so, because we just recently approved about a month or so ago the rates and forms for 2026 for individuals and small groups. Large group plans don't have that same, so they come in on a regular basis throughout the year. They can file them whenever.
Understood. What data or trends has DISB identified or DISB identified for delays in prescribing PrEP? And so, again, I think about the testimony we heard from Whitman Walker that in some instances, it could be up to 15 days of a delay while they're trying to get approvals from insurance companies. Do you all keep tabs on this?
So the way that we would identify those kind of things is when we receive insurance complaints, and we certainly encourage everyone if they have an issue with their insurance, to file a complaint with us. And we have not, based on checking with the staff, we have not seen complaints about that, which again doesn't mean that there's not an issue. So we will reach out to the insurance companies again. For PrEP, there should not be cost sharing limitations. but
Although
there-
we heard from one of the doctors today that a third of his patients
Right.
are being asked to share the cost.
So, yeah, and so, we can look into that to see where that is. I mean, there might be a combination of PEP and PrEP, because they can do cost sharing on PEP. But there shouldn't be cost sharing on PrEP. But again, we don't have any, we don't get regular data on that, but we can reach out to the insurance companies.
If you
and
could, I
see-
think that would
yeah.
be helpful, as it seems like there is a trend, and maybe it's not a widespread spread trend, but it is happening. If someone wanted to make a complaint, to this be about their experience with their insurer, how might they do that?
The best way to do it is to go to our website. There's on the main page of our website, there's a little indicator that says file a complaint. You can click on that and you can submit a complaint online, which includes the ability, I think, to upload documents if you have documents related to your complaint. But we can send you a complaint form. If you're not so computer savvy, you can call us and talk to one of our staff. But we or come into our office and submit a complaint, because we generally do need some kind of signature or authorization to
And
get
would
information.
you all reach out to that person, or is it a complaint that kind of goes into the abyss?
So when we get a complaint, the first thing we do is respond to the complainant to tell them that we have the complaint, kind of give them some information about our process, which can take a little bit of time, because we first have to evaluate the complaint, send the complaint to the insurance company, get a response back from the insurance company. Sometimes there's some back and forth, about that. And then once we come to a determination about the complaint, then we will respond to the person submitting the complaint. And also, we try to keep them updated on the status of their complaint, particularly if it's taking a longer time.
Awesome, thank you. A bit tangential, but I think that's important. Ms. Barnes, I wanted to come to you. Thank you for the work that you and your team have been leading for a while. Again, I can't tout enough how historic the gains that the district has made, and I think you and your team have played a huge part of that. In terms of PEP and PrEP access, and given the cut in federal funding to the district, I know you talked about some of the implications and community connections and outreach. How are you all thinking about mitigating or making up for that loss of funding? Or is it a matter of there's no way to mitigate it?
At this point, we don't have a way to mitigate it. And knowing that there are more cuts pending or coming, we're anticipating more next year. We are really looking at how do we move forward? Like, what does that look like from a change in priorities or prioritizing what we do and investing what resources we do have there? What brings us the best return on investment for the funds? Where do we see the most impact on those who we know need prevention services the most? Really looking at how can we best manage the resources that we will have and the people power that we will have to bring the most good to district residents.
I was really struck by Dr. Barnett at Children's National when he gave the stats about young people and the infection rates that we're seeing in young people. Not to put you on the spot, but I would just say, I hope as you're reviewing your strategies like that, we can collaborate to just double down on our outreach to young people across the district.
If I could I
yep.
tell you? So we are, HOSTA has recently entered the school-based health programs. And so we are going to operate the school-based health centers in the schools, as well as the high school health suites. where we will focus on empowering the young people to be more engaged and sufficient in what they're doing with their health, to understand how they can help protect themselves, as well as give them opportunities to learn and grow in those things that we know adolescents are challenged with, especially after the
I love
pandemic.
that. Transparently, I leaned over and said, is this the same school-based health program that doesn't fully exist and that we've been pushing to scale and deepen its impact? I don't make light of the effort. I think it's right. But if we could go beyond the school-based health program to reach as many young people in our schools as possible, I think the data, a quarter of new infections are, I forget the age range, but
Yep,
within our teenagers,
Yep.
that's like really striking.
Yeah, the other thing that we have is a youth-based initiative that we're working to build a coalition across the district to bring more information and education to youth-serving providers. I think a lot of times people are doing what they do really well, but not understanding the intersectionality of other things. So you may be a great primary care provider, but not really looking at how these things are affecting people's sexual health, sexual orientation, how that affects their mental status, and how all those things come together and combine into what we see in trends of people, of young people, getting infections, STIs, and HIV in higher rates. And so really trying to create a better strategy around how we all work together to help support those things as district agencies, as well as community-based organizations and others. I think the other place that we're making some impact is engaging the youth themselves through our youth advisory boards to make sure that they are having an opinion and are able to opine on what it is that we're doing, and make sure that those actions are things that will actually reach them in places that they look and they see. This is work that we've just started, but I think it will be impactful in how we move forward and how we help to move the needle on some of these things that we're seeing with young
And
people.
we were discussing earlier that for juveniles seeking STI treatments, they don't need parental approval.
That is correct.
Do you know the age threshold for that?
13.
So 13, under 13, they do need parental
Correct.
approval. Over 13, they can go access PrEP and PEP on their own.
Correct.
Are
That's
you
why it has to target at the high schools
are you tracking those numbers at all of
of people who access services without their parents.
yes, over the age of let's say 13, 18?
We don't track who right now. Not once we start providing services, we'll know. But right now we don't. We do track at the Health and Wellness Center, so I can get those numbers for you
Okay.
because we do see young people there. But I know that I have teenagers, just being transparent, and they kick me out the room when I take them to the pediatrician so that they can have those discussions without me and have those candid conversations that they need to have with their providers. And whatever happens there, the doctor does not tell me, and nor should they, so that my children know they have a safe place to go where they can get trusted medical information.
On the topic of the Wellness Center, for patients who access PrEP care through DC Health and the Wellness Centers, do you find that there are barriers to these patients obtaining PrEP through their doctors? And so I'm trying to get like numbers, and our friends at DISB are saying we don't have like the data, but we are hearing anecdotally that there are these delays. Are you seeing or hearing about these delays through that care through the Wellness Center?
So not necessarily delays. A lot of times what happens is that people, young people under 26 who are still on their parents' insurance, fear that their parents will find out that they are receiving PrEP or some kind of sexual health service, or know more about what they're doing than what they want them to know. And so they'll come to the Health and Wellness Center or someplace that's not their primary care office in hopes that that creates less stigma or more anonymity for them in receiving that service. We don't charge at the Health and Wellness Center at this point. We are moving into a space where we will be charging for some services, but we would not use ability to pay as a barrier.
Understood. And I'll close. I missed this as I ran to another hearing, but does DC Health support this legislation?
Yes.
And does DISB or DISB support this legislation? Okay. Thank you both for your testimony. Thank you.
Thank you, guys. Is there anything that you haven't been asked today that you just want to include on the record?
I just wanted to add a little blurb about DoxyPEP because
Okay.
you brought that up, because it's different than this PEP that we've been talking about related to HIV. DoxyPEP is using doxycycline to prevent STI infection, prevent chlamydia, gonorrhea, syphilis. And so it is a little different in the nuance and how it's more novel than these other forms of PrEP and PEP that we've been using, but it is highly effective and highly used in the district. We prescribe a lot of DoxyPEP through the Health and Wellness Center. We also do DoxyPEP starts at community events like the High Heel Race a couple days ago, at Black Pride, at Capitol Pride, any kind of community event that we pop up, we do DoxyPEP PrEP or PEP starts at those events, as well as HIV testing. And so I just wanted to bring out the nuance around DoxyPEP, and if that is the intent to be covered, then that's a different nuance than what is here.
Okay. Thank you. I appreciate that. And I want to thank you all for being here and for everyone who spoke on both of the pieces of legislation that we had today. The record will remain open until 5 p.m. on Thursday, November 13th for the public to submit testimony if you weren't able to testify today. You can do that on the council's hearing management system website, which is dccouncil.gov/hearings. We are going to do our best in terms of working with the committee. Well, they're two separate bills. On the first bill, in terms of community vaccines, that's just us, so we'll move forward. On this particular piece of legislation, it has been referred to both the Committee on Health as well as the Committee on Business and Economic Development, which has a little portion of insurance under their purview. So we'll work with them to hopefully jointly move this together. And just for folks to know, one of the things that we are thinking about actively is how do we minimize defrayal cost, because PrEP, PEP, and prevention in general is not included in EHB, which is the Essential Health Benefits under the Affordable Care Act. And so we have to just be very mindful of, if we want this to be implemented quickly, how do we make sure that we do so without an exorbitant cost on the back end? The Committee on Health will hold its next public roundtable next week on Wednesday, November 5th. At 10 a.m., we'll discuss the Department of Behavioral Health's new comprehensive plan for the school-based behavioral health program. There is no further business before the committee right now. The time is 11:32, and this hearing is adjourned. Thank you.